I'm going to introduce Dr. Bojana Srdanovic. She is an interdisciplinary qualitative researcher working in the field of disability studies. With a professional background at the intersection of social care and the arts, Bojana has extensive experience of working with people with learning disabilities, including in research and trauma. Her research interests revolve around care, including health and social care, community and social participation, and inclusive research methodologies. Welcome.
Hello, I'm Bojana. Thanks so much for inviting me today. And yeah, thank you in advance for your attention after lunch. I know it's a difficult session. Yes, I'm here today to speak about the project Humanizing Healthcare for People with Learning Disabilities. Before I begin, I must stress that I will be talking about instances of abuse and neglect. So I apologize in advance if that is upsetting or triggering to anyone. So before I begin, I will explain what the Humanizing Healthcare project is about in more detail, but just to sort of situate it around the topic of empathy. As I will elaborate, the concept of empathy is central to the concept of humanizing healthcare that we are developing within this project. At the same time, now, sort of like 2 years into the project, we have also found that empathy is not a panacea for reasons that I will address during the talk. And more importantly, we have found that for people who experience persistent dehumanization and social oppression, such as people with learning disabilities, collective social and political action is as important as a focus on how to empathize healthcare practitioners. So I will begin the talk today with introducing the project Humanizing Healthcare. I will then elaborate on empathy in the learning disability context and some of its challenges. And then I will turn to some preliminary findings and our research outputs. So, Humanizing Healthcare is a co-produced project. It's co-produced between the universities of Plymouth and Sheffield. The research center CIDA, which is not concerned with alcohol, but specializes in learning disability research, to NHS Foundation Trust of the NHS England, a University Health Board of NHS Wales, and most importantly, 4 self-advocacy organizations. So that is Speak Up in Rotherham, Barrel, who are located in South Wales, Standard and People First, and Sheffield Voices. The project Humanizing Healthcare really addresses the persistent dehumanization of people with learning disabilities in the healthcare context. It is concerned with persistent abuse and examples of inadequate practice really in the healthcare of people with learning disabilities. But it seeks to move sort of like beyond the criticism of healthcare systems and turning instead to affirmative research. So basically trying to find examples of existing positive healthcare practices. These healthcare practices, we sort of like have a placeholder term for these healthcare practices, and that is humanizing healthcare. And those practices we hypothesize are underpinned by principles of empathy, compassion, dignity, kindness, and recognition. Consequently, the project's research aims are to qualitatively investigate the cultures, conventions, systems, relationships, and practices of a neurology service in South Wales and a learning disability service in Cornwall. We seek to do so through co-production with researchers with learning disabilities, ethnography, and narrative interviews. Hereby, I must mention that while we co-produce methods theory, analysis, and dissemination strategies. The data are collected by 2 research associates. So that's Dr. Nikita Hayden in South Wales and myself in Cornwall. Our second research aim is to identify the ways in which these 2 services and the practitioners are humanizing healthcare for people with learning disabilities and or autism. So we have 2 sites for co-production. One of them is the executive team, where advocacy-based university and clinical researchers work together to lead, plan, design, implement, and review the research. In this sense, the executive team is really a location where people with learning disabilities enact leadership in research. So, and I think I will return to this during the talk, but one of the interesting things that we have found is that, sort of like 2.5 years into the project, that being positioned as, well, one might say authority figures, and I'm really sorry to kind of like turn Hobbesian here, but people with learning disabilities being positioned as research leaders and authorities to whom us university-based researchers are accountable, has in some very interesting ways shifted our expectations of ourselves and the research. So, yeah, and the second side are co-production workshops. I forgot to mention the executive team meets twice a year. But the researchers with learning disabilities sitting in that leadership group also participate in co-production workshops. They take place around every 4 to 5 weeks. And here we collaborate around distinct topics. So, for instance, method, theory, analysis, and dissemination. And yeah, currently we are focusing on analysis. So, empathy in the learning disability context. As I mentioned before, this research project responds to the valuing and dehumanization of people with learning disabilities. Here, it has to be highlighted that the healthcare of people with learning disabilities cannot be divorced from society's broader devaluing and dehumanization of people thus labeled. For instance, yesterday, I was in a hotel room, I was watching TV, and there it is once again, a scandal. There is a care provider called Lifeways where people with learning disabilities were basically neglected. I mean, this is all in the context of the care system, the social care system in the UK being such that one could argue that the bodies of learning disabled people are locations really where public money moves into private funders' hands, really. And so distressingly, there are reports of people being neglected to the extent where a mom put a camera up and their adult child was filmed eating out of bins at night. Somebody was admitted to hospital, and there it was discovered that their foot was basically had turned black. So basically, I guess, moving into gangrene. So these are all instances of neglect where these people are in care homes where they're meant to be looked after. So I apologize for these distressing accounts, but these are the realities that people with learning disabilities inhabit in this country. So in addition to these accounts of abuse, we also have the persistent phenomenon of diagnostic overshadowing, where symptoms of various diseases are erroneously attributed to learning disabilities, so that really the opportunities to adequately diagnose people are missed. We have witnessed blanket applications of do not resuscitate orders during the COVID-19 pandemic. there are sources from the US suggesting that in a context of limited resources, fewer resources, that there was basically a tendency to not give those resources to people with learning disabilities whose quality of life is stereotypically assumed to be low. So here we have a tragedy view of disability, literally determining the resources that people may receive. Perhaps interestingly for this context here, there is evidence of inappropriate prescription of psychotropic drugs, especially amongst people exhibiting so-called challenging behavior. And very few people, or there is evidence to suggest cautiously that most people with challenging behavior might not satisfy the criteria for mental illness. We have in our fieldwork spoken with people who one informant is a visually impaired person who was basically taken from their supported living environment to a residential care home for reasons that they don't understand. This was an experience that they interpreted basically like a form of abduction, so they had no control over what was happening to them. And while they were being in what they perceived manhandled in that care home, they punched a practitioner, which I'm not here to condone violence, but in many ways, I think when speaking with people who are accused of or labeled as exhibiting challenging behavior, it is very often a response to subjugation. And all of this, so one of the ways in which we can look at the dehumanization of people with learning disabilities is through the lens of stigma. So stigma here, we use it in this, as defined in the seminal work of the sociologist Lincoln Phelan. According to those scholars, stigma consists of 5 distinct but overlapping components of labeling, stereotyping, separation, status loss, and discrimination. Now, crucially to our research, to interpreting our research findings, stigma really requires the presence of power. So there needs to be a power differential between the stigmatized social group and the dominant social group that does the stigmatizing. So in other words, for labeling to progress to discrimination, there needs to be a significant discrepancy in social, economic, and political power. Yes, and of course, the inadequate care of people with learning disabilities dovetails also with complex health needs, so that those two combined result in people with learning disabilities dying on average 22 to 26 years younger than members of the general population. 49% of deaths of people with learning disabilities, so that is nearly half, right, are deemed avoidable. So yes, so that presents a picture where, considering the kind of like dominant views, I mean, this would be one of those cases where one might say, you know, we really need to work on the empathy of practitioners. And yes, there is evidence that there is a need for health interventions focusing on improving the communication between non-learning disabled practitioners and patients with learning disabilities. However, we also find that the dehumanization of people with learning disabilities is remarkably persistent, so across really recent history. This is because, or one of the main reasons is because perceived mental impairment makes people vulnerable to these forms of dehumanization. So in other words, since the Enlightenment, Western society has valorized the mind in ways that leave people with learning disabilities basically outside the remits of what is kind of like, or who is considered properly human. In fact, we can see this kind of like Cartesian sleight of hand also at play in the ways in which racialized and gendered bodies have been subjugated. So we know that, for example, the enslavement of Black Africans was rationalized with reference to alleged intellectual inferiority. We see the same sort of dehumanization leveled also at women, and yeah. So dehumanization on the grounds of inferior intellect is nothing new, but people with learning disabilities are the population where this kind of dehumanization continues to persist. What it entails is also a curious sort of like placing outside of culture and politics for people who are thus dehumanized. So that people with learning disabilities are essentially constructed as a sort of, free social other. And here it is then easy to forget that these are contingent conditions that can be actually addressed through collective social action. So yes, and one of the main, the central bit. So we fear that dehumanization and empathy are in tension, and I think that colleagues throughout the day have really touched upon this issue of partiality, so that otherness and empathy are difficult to consolidate. Self-advocacy organizations. So while we have in our research found that working towards identifying the practices of empathic and humanizing healthcare practitioners is important, they're kind of like learning disabled people's organization. So they are kind of like reclaiming of the status of the, human as a political animal, which has been a dominant thought throughout Western European history, is actually also a very effective way of resisting dehumanization and asserting humanity. So self-advocacy organizations, in other words, politicize people with learning disabilities and make them more conscious of their situation as not as pathologized individuals, but as an oppressed social group. In this context, self-advocacy really creates new kinds of empathic relationships and forms of support. And these forms of support could be replicated also in other contexts. So, for example, in the context of healthcare. And what is so valuable about these reviewed forms of support, if you like, is that they have been developed by people with learning disabilities who have, by virtue of their awareness of their socio-political position, developed more sophisticated accounts of what constitutes good healthcare, so having higher expectations of healthcare. So we have, for instance, in interviews found that when we have interviewed people from a self-advocacy background, they have been much more critical of the healthcare they have received. Then by contrast, when we have interviewed people with learning disabilities without that kind of like politicized background, they have often been full of praise really for the healthcare they have received, and nothing bad has ever happened. When we interview a close other, and stories emerge of neglect. So in that sense, we have to be really mindful of these kinds of like gaps in understanding that can be created. So we have sort of like attempted to triangulate more accurate picture of the healthcare of people with learning disabilities in the UK. So lastly, self-advocacy organizations are also central to the health and well-being of people with learning disabilities, not only because, so they are essentially locations of resistance from where collective social action is mounted in all sorts of different directions. So how benefits to the health and well-being of self-advocates and people with learning disabilities more broadly emerge is not only through activism that seeks to improve the conditions in healthcare, but also, you know, the kind of like benefits to well-being that arise from a collective social identity that is fostered in self-advocacy. And one of the ways in which to understand this, or one of the lenses through which to understand this, is by comparing two dominant models of disability. So on the one hand, we have the individual model that is dominant in the medical context. It is often actually called the medical model. It focuses on impairment. It equates disability with impairment so that an impairment always already leads to disability. It focuses on individual deficiency. It views disability as a personal tragedy. So in this account, obviously, individual adjustment under the guidance of professionals and through the means of medicine is seen as sort of like the only way out of this tragic situation. By contrast, the social model, which has been developed by disabled activists and scholars, so like since the early 1970s, focuses on society. It views disability as a social response to impairment. It focuses on societal deficiencies and therefore frames disability as a social tragedy. So really society's inability to adequately respond to the physical and mental, and I don't want to really split the mind and body, but okay, otherness. In this account, social change rather than individual adjustment is what's required. The social model emphasizes disabled people as the holders of knowledge of how to best enact these necessary social changes. And social activism is seen as the means to that end. Sorry, are we coming to? I've lost track of time. So some preliminary findings are that, so as I said, we are still in the phases of analysis, but so far some of the findings that are relevant to this context are that central to empathic practice are qualities such as kindness, seeing people with learning disabilities as human, and practitioners' clear communication. Humanizing clinicians, we have found, center patients with learning disabilities as sort of like experts in their healthcare. They are attentive and seek to remove disabling barriers. This is one of the reasons that we have recently been thinking about humanizing clinicians as perhaps allies to people with learning disabilities. Lastly, humanizing clinicians are creative communicators. And I think there is something very interesting about empathy because we have observed this creative communication often in fieldwork, and observed that practitioners who are able to creatively adapt to the communicative needs of their patients seem to have a certain kind of like what one might call empathic presence. And I think colleagues have spoken about this also today. Yeah, here's an excerpt from one of our interviews, and I have chosen this one just because, like almost all accounts, or almost all of our informants' responses to the question what humanizing practice is, almost all of the responses really emphasize being treated as a human. So yeah, this informant says, humanizing practice means just treating us with respect and dignity, remembering we are human beings. When you're talking to a person, especially one with a learning disability or autism, just remember to be calm, patient, and remember that try to not overwhelm people with too much information. Just try and keep it as simple as possible. Yeah, our research outputs, in addition to peer-reviewed papers, are a co-produced guideline for ethical co-production, reclaiming the human manifesto, which is still in preparation, and then a website that includes a digital exhibition. So as part of that digital exhibition, we are showing the work of our colleagues with learning disabilities, so mainly artistic outputs. For example, this poem written by our colleague Phoenix Bradley. I was going to read it out, but I think it is probably big enough for everyone to read it themselves. So I will give you a minute to read this. Thank you. Thanks so much for